Hi, I'm Dr. Brian Kaufman, a retired family doctor and a CLL patient myself. I'm also the co-founder, executive vice president, and chief medical officer at the nonprofit CLL Society. And I'm here at the first opening day of ASH, the American Society of Hematology's annual meeting in San Diego. Dr. Tadmor?
Yeah, my name is Dr. Tamar Tadmor, and I'm at the head of Hematology unit in Bnai-Zion Medical Center in Haifa, and the head of the Israeli CLL study group, and I'm happy to be here.
It's wonderful to see you again, and you've done some really groundbreaking work in a number of areas in CLL that we've talked about before. But one paper that you're presenting here at ASH really caught my attention, and it's something that's, I want to say, of interest to patients, maybe of a concern, and that's about artificial intelligence and machine learning in managing cancer patients. Can you talk to us a little bit about that? Just remind us what's artificial intelligence, what's machine learning, and then we'll talk about the specifics of your paper.
So I think the difference is when we are using machine learning methods is that we are not selecting, we are not biased in deciding what affects and what do not affect the treatments and the side effects. We let the machine to select for us in an unbiased method, and then we learn new things. And this is what we did in our machine learning approach to identify who are the patients that are in risk to develop atrial fibrillation.
So we know atrial fibrillation is a high risk for people on BTK inhibitors, and one of the questions is who's a patient at risk? And obviously if they have a history of atrial fib or something like that, but you went further than that so you could better identify and maybe help risk stratify the patients. So tell us a little bit about what your research was, how the study was designed, and what your findings were.
So first of all, we have defined the system to select more than 100 variables. So we had a lot of variables that we learned to see which one of them will have an impact to identify patients who are at high risk for atrial fibrillation. Second, we defined that we want to have in our risk score not more than 10 variables. And the third thing that we have defined is that we wanted that all the parameters that we use are available worldwide. So not unique parameters, not genetic tests, but tests that are available for each patient.
So in low and middle income countries, they could also use the same thing.
Exactly. And so when we used this system of machine learning, the machine picked up the parameters and then repeated again and again for more than 10 times to be sure and to validate that our results are indeed the correct parameters that we have chosen. So we used a very big cohort that we have from one of the leading health medical insurance that we have in Israel, and we identified more than almost 4,000 patients with CLL. And out of them, we picked up only the patients who started BTKI during that period.
Bruton tyrosine kinase, so that would be ibrutinib, acalabrutinib, zanubrutinib, and in the countries where it's approved, pirtobrutinib.
So what is unique in our score, because there are already available other scores for prediction of atrial fibrillation, is that we had both patients on ibrutinib, but also on acalabrutinib. Not yet on other BTKI, because we don't have enough time that are
enough data points to make anything valid.
Exactly. Yeah. But we had 208 patients who started BTKI during the period of that we investigated, and 125 started ibrutinib and 83 started acalabrutinib. So we were able also to compare the risk between these two drugs. So you want to discuss the risk?
Yeah, so what did you find? That's what I want. That's what the patients want to hear, yeah.
Okay, so we identified that the convention, the very new used risk factors were identified also in our work, meaning that elderly age above 80, having past medical history of diabetes or hypertension, and males are at higher risk for atrial fibrillation. But what was new in this unbiased system is that we identified some parameters that are associated with inflammation, like the number of monocytes, which are a subtype of white blood cells, that when they were high, they were associated with the development of atrial fibrillation. Also the CRP, a parameter for...
Right. C-reactive protein, which is a marker for inflammation.
Exactly. Yeah. And other markers like the beta-2 microglobulin, which is related to the CLL mass. Yeah. And so we were able to identify 10 parameters and to generate from them 3 risk groups. One, which is a low risk group to develop atrial fibrillation, and one intermediate risk group. And what we are interested is the high risk group, that for these patients who are in risk to develop atrial fibrillation, we need to give more attention and to do maybe a closer follow-up. And
did you find any difference between the ibrutinib and encalabrutinib? Was that part of your trial?
Yeah, so one of the 10 parameters that went up is the patients who are treated with ibrutinib were in a higher risk to develop atrial fibrillation indeed.
Yeah. So any final thoughts or things that patients should know about sort of as a takeaway from your research?
So we know now to identify who are the patients who are at high risk for atrial fibrillation. So we need for this group of patients to follow better. And I think another important message that came out from my study, but also from other studies, is that the development of atrial fibrillation did not affect the overall survival or the progression-free survival of patients. So it's we don't want to have these side effects, and we need to manage it, but it won't affect the overall survival, at least based on our data.
Well, that's really good news. Dr. Tadmor, this is innovative research. It's reassuring research in a lot of ways. So thank you very much for what you and your team are doing. Thanks so much.
Thank you.